Hello, my name is Tapan Kadia. I am currently Associate Professor in the Department of Leukemia at the MD Anderson Cancer Center. In this module, we're going to be talking about treating acute myeloid leukemia with MDS-related changes. In a previous module, we explored the underlying adverse prognosis associated with this subset of disease. And in this module, we'll talk about exploring what are the best treatments for this particularly difficult subset of acute myeloid leukemia. And in order to do this, we actually went back and looked at our own experience between 1990 and 2015 of patients with this diagnosis of AML with MDS-related changes. And these could be patients who had known prior history of MDS, MPN, or CMML, patients who had therapy-related AML, or patients who had a karyotype in their AML which was characteristic of MDS by the WHO classification. We looked at various treatments that we had given them over the past several years, whether it be high-dose Ara-C-based intensive chemotherapy, whether it be hypomethylating agents, whether it be low-dose cytarabine-based combinations such as cladribine low-dose Ara-C or clofarabine plus low-dose Ara-C. We looked at our own experience with a drug called CPX-351, which was recently approved for patients with secondary AML. And we looked at how patients did when we gave them investigational single agents. So it was a retrospective study looking at the question of how did we treat these patients, and among these patients, who did the best. Now, with a retrospective study comes its own biases. And so we know that patients who were treated were likely treated based on the physician's preference. And so you can see this is a busy table, but I'm going to point out some important characteristics. We can see here that the patients treated in the high-dose cytarabine arm were, on average, younger, and we had less patients over the age of 70 in that arm, which makes sense. We treated younger patients with more intensive chemotherapy. Patients with HMAs, on the other hand, were a bit older on average than the intensive chemotherapy-treated patients. So clearly, that makes sense that we were giving these patients therapy that was suitable for their age and potential comorbidities. In this here, we see the disease characteristics of these patients, and we've reviewed this in the past, but patients with AML with MRC tend to have lower blast counts, lower white counts. And what's interesting is they have had a prior history or prior therapy of receiving therapy for their antecedent hematologic disorder. And you can see here in the different columns of high-dose Ara-C-based therapy, HMA-based therapy, or CPX, that there are different proportion of patients in each group who have received prior HMAs. And you can see in the HMA group, the least number of patients had received prior therapy for AHT, which would make sense since we're not treating these patients again with the same therapy. Patients in the high-dose Ara-C arm, about 20% of them had received prior therapy, and the CPX arm, a large percentage, 65%, had received prior therapy for their MDS or MPN. And this is important because we also recognize that this particular subset of patients, which we refer to as TS-AML or treated secondary AML, have a particularly adverse prognosis in the subset of patients who have AML with MRC. We can also see that in the low-dose cytarabine-based combos, there is also a significant proportion of patients who had received prior therapy, likely with HMAs in that setting. We can see that the majority of patients here have an adverse karyotype. Over 50% in each case had adverse karyotype in their treatments. And these are the outcomes. We can see here the remission rates and the 8-week mortality. And let's go through this one at a time. In the high-dose cytarabine column, we see that the response rate was probably among the highest we see, which is about 46% in this very difficult population. But it came at the cost of significant increase in mortality, where the 8-week mortality was 23%. Pretty high mortality in this population, so probably unacceptable given the high response rates. You can see in the HMAs, the 8-week mortality much lower, but also lower response rate. And then the next two columns, but the CPX-351 or the low-dose cytarabine, we see sort of a sweet spot maybe where we see remission rates in the range of 43 to 45%, but a acceptable early mortality potentially in the range of 10 to 19%. And so a potential strategy could be to use one of these agents in the treatment of patients with AML with MRC. You can see here the overall survival. The patients who did the worst are in the intensive chemotherapy or the single-agent investigational therapy, whereas those who received CPX-351, which is the green line, or the low-dose Ara-C based therapy, which is the yellow line, probably did among the best with a median overall survival of 7 to 7.6 months. This is a slide just quickly looking at those patients who had prior therapy for their MDS, so-called TS-AML, and you can see, compared to therapy-related AML or even de novo AML, lower rates of complete response, higher rates of 8-week mortality, kind of summarizing really adverse prognosis associated in that subset of patients. I'll spend a couple of minutes talking about CPX-351, which is a new drug, a brand name Vyxeos, which was approved recently for the treatment of patients with secondary acute myeloid leukemia or those with AML with MDS-related changes. It is a liposome delivery agent, which inside it includes a 5-to-1 molar ratio of cytarabine to daunorubicin. So the overall total doses of cytarabine and daunorubicin are lower than what we would give in 7+3, but they're at a specific synergistic molar ratio. CPX was developed in phase 1, 2, and 3 trials. Initially studied in relapsed and refractory AML, where the MTD was discovered to be 100 units per meter squared. This was then moved into a randomized phase 2 study of newly diagnosed older patients with AML with a planned analysis in there of secondary AML. And what they found is that although the overall response rate and overall survival was no different than 7+3 overall, in this planned secondary subset, they saw improved response rates and event-free survival and overall survival. And this led to the phase 3 study where 309 patients with secondary AML or AML with MRC were randomized to CPX or 7+3. And what they found, as we know, is that there was a higher rate of complete remission as well as complete remission and CRI in the CPX arm compared to standard 7+3. Additionally, there was lower early mortality with CPX-351 at 30 days and 60 days in the CPX arm compared to 7+3. And this, of course, led to a significant improvement in median overall survival in this patient population of AML MRC with a survival of 9.5 versus 5.6 months, which was statistically significant. When they looked at this in age groups of 60 to 69 as well as 70 to 75 years, the survival benefit was present in both subsets of patients. Furthermore, when they did a landmark survival analysis at the time of transplant, so patients who received transplant, whether they got 7 and 3 or CPX, you can see that those who received CPX-351 had a significant improvement in overall survival after transplant compared to those with 7+3 who then went on to transplant, suggesting either that they had a better and deeper response with CPX-351 or were potentially in better shape with CPX-351 after the therapy than they were with 7+3. In summary, AML with MDS-related changes represents a common and important subtype of AML associated with inferior outcomes. Standard approaches with intensive chemotherapy regimens in this subgroup is associated with high early mortality and inferior overall survival. Newer approaches using low-dose cytarabine-based combinations or CPX-351 show good response rates, lower early mortality, and better overall survival. CPX-351, which is a liposomal formulation of 7+3, demonstrates significant improvement in overall survival compared to 7+3 in patients with AML MRC, including after stem cell transplant.